So we're going to talk a little bit about two topics, supplemental oxygen and pre-oxygenation. The basis for this is that our cells need oxygen in order to produce sufficient energy and produce it efficiently in order to have normal function. And so oxygen is necessary for our cells to do cells business, which means we have to bring oxygen in through the alveoli at the very bottom of the bronchial tree to the tiny air sacs called alveoli, where the bloodstream is able to mix with that air in direct contact, essentially. The alveoli therefore have to have enough air moving in and out, and that air must have sufficient oxygen in it, and there has to be sufficient circulation to the alveoli for the whole process to work. Now, normal room air has about 21% oxygen in it, but in some cases that may not be sufficient for the patient's needs. In crisis situations and disease states, patients need more oxygen. So that's the basis for our need to provide supplemental oxygen. We carry our oxygen in D tanks, and they provide about a minute of flow at 15 liters for every 100 pounds. So if you're trying to estimate how much time you've got left in your oxygen tank at 15 liters, which is what we typically supply our bag valve mask as well as our non-rebreather mask, you have about a minute for every 100 pounds. It's important that you check your tanks. You don't want to get into a call and need to swap tanks. And so truck checks and O2 tank checks are an important thing. We should have two tanks in our trucks, and so it wouldn't hurt to bring that second tank in. If you're the fourth or fifth person arriving in a medical emergency and you know that O2 is being used, or you know that a resuscitation is in progress, stop by the truck, pick up that spare tank, and it would help us to have that second tank in the house in many cases. A number of different O2 delivery devices. The nasal cannula in the top left corner is the one that we typically use, and then the partial non-rebreather mask is pictured in the center in the bottom and on the bottom right. And we call those non-rebreathers, and that's fine. We'll continue to do that. But technically they're partial non-rebreathers. If you look at them and compare them to the photo in the bottom left, you'll see the photo in the bottom left is a true non-rebreather, has both valves covered so that no room air is inhaled by the patient when the patient takes a breath, whereas the ones that we use in the bottom center and bottom right have one of those valves removed, and that's fine. That helps us in the cases where our O2 tank runs dry, but what it does is that our patients are probably at maximum getting in the 75 to 80% range of oxygen. And then in the top center, you see a Venturi mask. Those are very uncommon in the pre-hospital setting. Some chronic lung disease patients may be on those in lieu of a cannula. And then the top right is a simple face mask, a mask without a reservoir bag, whereas your rebreathers, either partial or non, the rebreathers will have that reservoir, the simple mask will not. So for the fire district, we carry nasal cannulas and what we call non-rebreather masks, but your patients that you encounter may have some of the other devices. We typically supply 4 liters with a cannula, and that provides us about twice the inspired oxygen, FiO2, the percentage of oxygen that the patient's inhaling. It's about twice that of room air. So if your patient's on room air, they're at 21%. If you go to 4 liters with a cannula, that'll essentially double it. And one of the new trends that's out there is that some unresponsive patients who need to be pre-oxygenated can actually tolerate high flows with a nasal cannula, whereas the conscious patient, once you get over about 4 liters, the cannula becomes very uncomfortable for the patient. But we may use much higher flows as time goes on here for pre-oxygenation through a nasal cannula while you're using a bag valve mask that's also connected to oxygen. It's just one of the things that's coming down the road for us. But our standard for patients who have signs of shock, signs of hypoxia, meaning they're breathing rapidly, breathing shallow, to the point where we can't support with ventilation, but are still not breathing adequately. They have a abnormally high or slow rate, using extra effort of breathing, or not breathing deeply enough. And if we've decided not to ventilate, then the non-rebreather mask is our tool. And the non-rebreather mask can essentially double the flow from the cannula. So if you got room air at 21%, you can essentially double that with a cannula at 4 liters, and then double that again once you switch to a non-rebreather mask. The flow rate for a non-rebreather mask is at least 10 liters per minute, or as much as 15, and it's technically, it's the amount of O2 necessary to keep that reservoir bag at least 1/3 full, so your patient isn't able to breathe from that bag and collapse it more than 2/3. 10 liters is probably the minimum for that. Some patients may need up to 15. As we start talking about pre-oxygenation, this is when we're going to have interrupted ventilations. We're going to place a combi tube in our case, or we're preparing the patient for an endotracheal intubation by paramedics. And pre-oxygenation should entail the standard tidal volume, so the same amount of breath, the amount of volume that you normally move, and the same rate that you normally move. We don't hyperventilate our patients, but we do need to pre-oxygenate them or hyperoxygenate them, which means, again, standard ventilation rate and standard volume, but with as much oxygen as we can possibly flow. And our regulators on our D-tanks will go up to 25, and so we should switch those to 25 liters per minute. And we did a test on this to see how long an absolutely full tank would last, and we got right at 20 minutes out of that tank. So that shouldn't be a problem for us. But we're going to pre-oxygenate before we interrupt ventilations, and we're trying to do maximum oxygen flow, but at a normal ventilatory rate and a normal ventilatory volume. So in summary, high inspired concentrations of O2, high O2 percentage delivery is indicated in some circumstances when we have signs of hypoxia or shock. When those signs are not present, a nasal cannula at 4 liters is just fine. That essentially doubles what the patient would be getting from room air, and that will usually work for us. And then this is essentially our standing operating guideline for O2 therapy. Basically, we have low flow, we have high flow, and patients who are not on home O2 and don't need high flow are served just fine with a cannula at 4 liters. Once a patient shows signs of shock or hypoxia, then we're going to switch them over to a non-rebreather mask. For our patients who are on home oxygen, we can go ahead and leave them on what they are on. Leave them on their low liter flow and the device that they're using, as long as they don't show signs of shock or hypoxia. But again, once any patient shows sign of hypoxia, they should receive oxygen with a non-rebreather mask. So that's a general summary of oxygen delivery and some introduction to pre-oxygenation.